for a congress in the UK. Heart Rhythm Congress is a national conference in the UK. We did live electrical optimization. It's on the video's on YouTube. I'll see if I can share it via the guys to you. It's quite, one of our registrars from the hospital did it alongside us. So patient one's called Vicky. It's not her real name. She wanted to be called Vicky for the filming, so we're like, okay, you can be called Vicky. So she is a, this is her, so she's a 76-year-old female. She was getting increased shortness of breath, and she only presented to her family doctor because her shortness of breath was impacting on her dancing. She loves going dancing, and she just said, right, I can't dance anymore because I get short of breath. I'll go see the doctor. She went to see the doctor, and she also had PND and orthopnea. She comes to see the doctor. She's a lovely lady. She's like, it's the dancing. Everything else, walking down the road, short of breath, ignore that. It was the dancing, right? So anyway, so she has severe left ventricular systolic dysfunction, left bundle branch block. She went from 3 to 2 diuretic therapy. She's a bit of a history of myocardial infarction, and all the drugs are on the right-hand side. So would you put a CRT into this lady? Yes? 100%, yeah? You put a CRT in. This woman is a barn door CRT, right? She's got low scar burden as well, right? So she's got low scar burden, proper left bundle. If we get a good vein, we're gonna make her feel, well, we should make her feel good, okay? So we went ahead and we put a CRT into her. Her ECG implant was left bundle, 190 milliseconds, normal sinus rhythm, PR interval, importantly, PR interval is important here, is 175, left-sided implant, 3 axillary punctures, single coil lead, put a CRT in, put that long, and we put the long-spaced LV lead, okay? And when I mean the long, so the long spacing of the electrodes. So that's what we try to do a lot in the UK anyway, is use these very wide-spaced electrodes, because what that allows you to do as a physician is to bury the lead into the apex, right? But not paste the apex, because we know, probably, well, we know that if you paste the apex in something, left ventricular apex, you're probably going to get a worse outcome. And it's mortality. Okay, so if you paste LV apical, it's a significant. There's Matic CRT showed that. Can't remember the name of the other trial that showed that, but there is a mortality curve difference and a morbidity, right? So we should paste basally, right? Which often equates to the QOV. So when some people don't measure QOV, you just paste a basal left ventricle. It's probably all right. You probably don't need to measure because the two are equal, right? Okay, so we did that, and then here's our X-ray. Any thoughts on our chest X-ray for her device function? So the doctor who put it in is a guy called Paul Sheridan. He's a really good cardiologist. Quite a good cyclist as well. Nice guy. Anyone? Got any comments on his lead placement? Looks good. Yeah. Just good. Did you just get good? I'm going to tell him he just got good. He'll be upset. The vein, I did have a video, but I had to pull the video out because it was using up too much memory and my iPad couldn't take it. But to get that lead into that vein was really tricky. So he used a snare technique. Yeah. So snare technique means you could get the lead in, but not very far in. So he pushed the guide wire through the vein, through the lead, down through the lateral branch, back up the middle cardiac, so kept pushing. It goes all the way around. It comes back out again. Then he took a snare, put a snare through the delivery catheter, grabbed the guide wire. So you hold the guide wire tight, and then the lead just smoothly moved over that wire. Beautiful technique. Has anyone done it here? Has anyone snare here?
Without the snare, next case.
No, don't. So you need to look up Seth Worley. Have you ever heard of Seth Worley? He's got a very active Twitter profile. Seth Worley is a physician from the US, and he invented some catheters and does a lot of very nice videos on YouTube and Twitter of using snare techniques. If you can't advance the lead, it's a nice technique.
Tributary to
come back
to the right atrium.
And then pause. Not like that, obviously, because then you cheese wire the heart. But so you have to be careful, right? But
PCA also.
Huh?
We did a little dilatation.
Yeah. So we snared it, pulled it through, got a beautiful lead position, really nice lead position. So And then we switch on, so then here's her underlying rhythm. So her GQRSD, so GQRSD is global QRS. So that means that's her overall of every lead. We measure every lead on the 12-lead ECG. What we normally do, we put the rigger up to an EP system, and we just put all 12 leads like this here, 100 speed, and put calipers and measure it, okay? So we started off with a QRS duration of 200 milliseconds. Good indicator for CRT, right?
Yeah.
It's notchy. Yeah, it's got the notches, which is the dissociation, the electrical dissociation. And, you know, we're putting a CRT in, so we're fixing left bundle. And she's got left bundle. So we need to change that dramatically, okay? So we turn on our CRT. Oh, we don't turn the CRT on. We do some LV testing. So this is LV only pacing at D1, okay? So D1, don't worry about the return pathway. The return pathway is M2. So this is pacing the distal end of the left ventricular lead, okay? The tip of the left ventricular lead. So is this at the base of the left ventricle, mid-left ventricle, or apical left ventricle? Where? Apical. And how do you know that's apical? It's not. It's kind of mid-apical.
Just mid cavity.
Yeah. Because so you're looking at the transition point of the ECG, yeah. So when you pace LV only and look at the precordial leads, the point at which it flips tells you whether the apex of the left ventricle, mid left ventricle, or base of the left ventricle. If it stays positive in 1, 2, 3, 4, and 5, and 6, you're at the base. Okay, if it transitions here, you're probably pretty close to the apex. You're pretty close to the apex. So this, if we pace off this is probably harmful, or potentially harmful. It might be better than left bundle, but we probably shouldn't do it. So then we'll go to, we'll pace our left ventricle from P4. Transition point moves to here. This is better, okay? This is more now towards the base of the left ventricle, okay? So LV only pacing, and interestingly, just go back. Let's really try and identify exactly where it is on her left ventricular wall. Okay, it's lateral because it's positive here. It's towards the apex. And is it superior or inferior?
Superior.
AVF. So it's moving away from her feet. So it's moving superiorly, yeah. So it's at the inferior part of the left ventricle. So this is infralateral and apical. So if you had a heart model, you could probably point out exactly where it is. But those are the three things you look for, right? You're going to identify the pacing side. And sometimes that's helpful, especially in follow-up. Because if you're a follow-up and you're changing the vector on the LV lead, you want to make sure you know where you're pacing, right? So you just do a 12-lead ECG, pace an LV only, and then you'd be really quite accurate to where that pacing site is. So let's now move to P4. So D1, M2, M3, P4 is the one furthest back on the LV lead. Where are we pacing now? So if you had to identify in a heart model now where it would be. It's lateral. It's mid-stroke basal, closer probably to basal, and superior. Superior-ish. In between. It's in between. It's biphasic, right?
Yeah.
It's biphasic. So it's kind of, that's in a perfect position, right? That's the electrode that I want to be pacing off. Electrically, anatomically, I want to pace that site, okay? Probably, okay? So off we went. This is out of the box settings. This is no change to any settings. This is just as it came from the factory. So it's pacing D1, AV delay of this, VV offset of that. Happy? We let her go? No, it's rubbish. It's rubbish. It is still negative in V1. This is rubbish. This is better than how she came in, okay? It's better than where she came in, so she will probably respond, but we could probably make her respond better, right? I can make that. We can make that. We should be able to make that better, right?
Yeah.
So we then start to make some changes, and I'll go through the changes when we get onto the program in a second.
Positive in 1 and AVN 2.
Huh?
Positive, QRS is positive in 1 and AVN 2.
Sorry, turn them up. I don't know why I haven't turned the program on. Better. We've moved past some stuff there. So this is how she came in. This is how we out of the box settings, which we never use, right? It's not good enough. It looks like left bundle, like slightly less left bundle pattern, right? It's not a great picture. So then we did some optimization, and this is optimization using QuickOpt. So QuickOpt, I sort of spoke to you earlier about it. It's the thing that measures the P wave, but in a CRT it can also measure the midpoint electrically between the right heart lead and the left heart lead. I'll show you how to do that in a second. So this is using, so we're at latest activation, measure the QLV, quick opted it, so we got what we think is an optimal AV delay and an optimal VV delay. So this is patient P4, AV delay of 130, a VV offset of 55. Okay, i.e. the LV is paced at 130, the RV is paced at 130 plus 55. That's what it means on an Abbott device, right? When we go LV first by 55, the LV is paced at the end of the AV delay, and you delay the RV. Okay? How's the rhythm? Oh, worse.
Like the previous one, but the QRS gets wider.
So it's worse. So we just made it worse.
It's worse. It looks like her native.
We need the LV to proceed, not to...
We did. There's the LV is preceded by 55. Reduce the... This one? Or this one?
I think you have to play the
Yeah.
55 is too much.
55 is too. 55 is too much. Okay. Well. What? Yeah.
Looks like her native.
It looks like a native conduction, right?
Yeah.
So what, if we think about this, right? Let's just work out what's going on. Yeah, there were a few. Yeah, absolutely. So we're LV pacing at 130, right? What was her PR interval? It was 190, right? So we're LV pacing at 130, and you know, let's go back. Let's go back to when we LV pace. So when we LV pace, you can see it really nicely in this lead here. So you can see this delta wave here. Yeah? That delta wave is the epi to endo conduction time, okay? So that's the time it takes for the LV pulse to go from outside the heart to the inside of the heart, and then to start moving quickly. Once it gets inside, it's really quick, right? So epi to endo conduction time. So you pretty much always need a VV offset, because otherwise, if you don't compensate for this, the RV wavefront, which is coming from inside the heart, has hit the LV electrode, or it's got very close to the LV electrode, right? So it abolishes, so you get left bundle branch appearance, right? Okay. So you have a normal PR interval of 190, and we are pacing one LV at 130, and then we've got that delta wave, that delay, which looks significant, right? Out to wind looked quite significant. We were out in SCAR, that outside to wind looked well, normal. So probably by the time it gets to the inside of the heart, we're now at a PR interval of 170, okay? And her AV node is conducting. It's not stopping, it's coming through the AV node. It's probably in the ventricle now and coming towards the RV lead in fast conducting fibers, okay? Yeah? So then we delay the right ventricle by 55. So we're going to place the right ventricle at 185.
Paul, can I interrupt you?
Yes.
This is politically stop of the Nasser City Hospital. He's coming to welcome you.
Thank you.
This Mr. Paulo, the educational manager of Abbott UK.
How'd you do? Welcome. Thank you very much. Thank you. Nice to meet you.
Also, we honor the presence of Dr. Rania Samir, the professor of electrophysiology, and her team here. Because we starting maybe very soon, as I told you, the launching of electrophysiology department, and we shall need your help regarding the equipment and arrangement. I assigned Dr. Mansour to lead the electrophysiology team in Nasser City Hospital under supervision of Professor Saeed Khalid, Professor Rania Samir, and also Professor Mirvat al-Muati. She was here 1 hour ago, but she went for a special mission. I think the number of attendees is less than the early morning. This is very advanced workshop. Really, I just understand only 30% of what you say, I'm not an electrophysiologist, I am an interventional cardiologist, but I think Maawad understanding 100%.
110.
I have, we have doctors from all centers of Egypt, National Heart Institute, Ain Shams University, Ministry of Health, also the Fellowship of Electrophysiology under supervision of Dr. Mervat Al-Maafi. I hope it is honor to Nasser City Hospital Health Insurance to gather all these specialists from all centers all over the country. It is an honor to meet you, Paul, in Egypt, and we are proud of our General Manager, Dr. Ahmed Atta, that he will help us to launch the electrophysiological department. Thank you, Dr. Ahmed. Okay, we are sorry.
No problem. Thank you.
إذا كنت عايز تقول حاجة بالعربي بقى أو بالإنجليزي.
بالعربي احنا طبعا لا طبعا برحب بالناس اللي من بره كلهم. مدينة نصر كمركز قلب بفضل مجهود دكتور محمد غريب، دكتور امجد، دكتور منصور، كل الزملاء،
كل الناس.
المركز الحمد لله يرفع سمعة طيبة. نتمنى ان الورك شوب تكون مفيدة. نرحب بيكم في المستشفى. نتمنى ان هي تتكرر كتير يا دكتوره. ان شاء الله. ان شاء الله. كان نفسي اكون معاكم من بدري بصراحه، ويمكن وعدت الدكتور محمد ان انا اطلع قبل ما نبدا، بس الظروف خارجه عن ارادتنا كلنا. اضطرينا ان احنا نطلع دلوقتي. ان شاء الله الورك شوب القادمه نكون احنا مستعدين ليها كافراد اداره اكتر من كده، ونكون عدد الحاضرين ان شاء الله يكون اكتر من كده، وتبقى الفايده
مسجلين الصبح ساعتين.
كان كتير
طبعا.
بس طبعا الساعه 2 دي تبقى بتفرق بقى.
لا ان شاء الله المره الجايه.
لا بكره هتلاقي، لا بكره في ورك شوب هنكملها بكره. انا اعتقد الناس لما تسمع الساوند بتاع النهارده هيبقوا بكره اكتر من كده.
بتمنى ليكم ورك شوب ممتعه، واتوقع ذلك في وجود مستقر مصر ووجود محمد. شكرا ليكم.
شكرا لك.
We made it worse. Yeah, we made it a little worse. But we shouldn't be surprised, right? We shouldn't be surprised because remember, we're pacing the LV at 155, at 130. We saw a delta wave, which is normal. So there's a delay till that gets to the inside, till that starts moving. And then we paced up right ventricle at 185, and she has PR of 190. So this here is her intrinsic rhythm with a little bit of fusion of LV pacing and RV pacing. This is rubbish. This is not good enough. Not good enough. We don't like this. But it gets better. Don't worry. So then we start to make some other changes. This is then going VVI. Okay. So sometimes when you're optimizing, you want to go VVI and exclude all fusion, right? Get rid of the fusion. So ignore the PVC. Is this better? This is narrower, right? We have got better CRT, right? Let me go back. So that's better, right? So I've taken away the fusion. I've taken away our intrinsic conduction. So actually, the quick opt algorithm got the VV delay pretty close. Okay. Pretty close. Well, this is by V now. So this is by V now, right? So it's a little bit too much LV. So maybe we need to bring it by 10. But the VV part of quick op was pretty close. Okay. Here it looks like it did a bad job. Okay. But actually, when you take away fusion, when you remove fusion, it was pretty close. Okay. All right. So the VV part to the quick op does not look at intrinsic conduction. Doesn't consider intrinsic conduction. It just measures the time in between. So it paces the RV, works out how long that takes to get to the LV chamber, the LV electrode, paces the LV, how long does that take to get to the RV, and then it works out the midpoint. Tries to get those wavefronts to collide somewhere in the midpoint, okay? So actually, it was pretty close. I reckon it's about 10 milliseconds out, so it's not too bad, okay? Anyway, so we adjusted a little bit, we bring it in a little bit more, we think probably 35 or 30 was okay. So I'll move on. Then we'll make this change here. So now we've gone latest activation with a VV offset of 25. Better? That's pretty good, huh? We like that? That's got significantly narrower, okay? So quick up was about 15, 20 milliseconds out, okay? So we don't completely rely on an automatic mechanism in the device, right? Yeah? We run the buttons. If it looks really good, it's good. It's got it well. Sometimes it may be out by a bit. So looking at some kind of marker, not just blindly believing the thing that you get. It's like watching the TV, you know, the news. You don't just blindly believe it. You kind of, you know, assess it yourself a little bit. So this looks pretty good, right? But this is in VVI mode. We're not going to do that with this patient. Let's go back to, so what about this here? What about this ECG? This is now using a technology, this is now using a function called SYNC-AV. So SYNC-AV uses the patient's right bundle to activate her left ventricle as well. Okay, she has an active right bundle, it works fine. So we allow a little bit of fusion to come through. So a little bit of fusion comes through. So here we have a patient P4. The AV delay is SYNC-AV. Okay, so it measures the PR interval and it takes 50 off it. So we're now pacing at 130, because it was measured at 180. LV is paced at 130 and the RV 30 milliseconds later. This is a slight improvement on our other dual chamber, isn't it? To go back, not on the single. It's a slight improvement on, not a slight improvement on that. Not a lot in it though, okay? All right, so this is SYNC-AV. I'll go through SYNC-AV in a bit more detail in a minute. So this is utilising SYNC-AV. Still a little bit broad here. Don't particularly like it. So now I'm going to optimise this number. Okay. So when at minus 50, what does this mean? This means that we pace the left ventricle at 50 milliseconds less than their PR conduction. Okay. So we allow some intrinsic to come through, and then we pace the left ventricle and the right ventricle. So we have now 3 wavefronts. We have a wavefront coming from the left ventricle, the right ventricular lead, and her intrinsic conduction. Okay? So it's called fusion-based, we call this fusion-based CRT. And you can produce some phenomenal ECG results using this, and clinical outcomes. So at the moment, we haven't got it right. This takes 10 minutes, right? Here, we've now made the delta less. So we've changed that delta. The ECG changed. This has got worse. This has got worse. Okay? So at minus 30, we've got more intrinsic coming through. Okay? There's more intrinsic breaking through. The ECG jumps out, goes wider. Right? Okay. We need to go the other way. Now we take it to minus 70, and we can see we've probably got a little bit of more shortening here. Okay, but we're still not exactly where we want to be. We have got QRS reduction, but we're not good enough just yet. So minus 80, we played around. So minus 80 is getting quite short now, right? We're getting shortening. We're getting incremental shortening by optimizing this aspect here. So we're adding in. We're removing a little bit more of the fusion. Okay, so we've got RV, LV pacing, and intrinsic conduction. And this was about as good as we could get. This was about as good as we could get using single point pacing. So we're pacing P4. We're pacing the left ventricle at minus 90 off her intrinsic. So that is at, let's say, about 100 milliseconds. So we're pacing or 90 milliseconds, pacing the left ventricle at 90, and we're pacing the right ventricle 30 milliseconds later, okay? But there is some intrinsic coming through here as well, okay? So we've got 3 points. 1 point, the RV point, and also her intrinsic. We've got a nice reduction. But we want to try one last thing to try to see if we can do any better, okay? The last thing we tried, the next stage in our protocol is to use multi-point pacing, okay? So multi-point pacing, you pace from 2 separate anatomical, so far away points on the left ventricular lead. So D1 and P4, you pace those 2 points. So biggest anatomical separation. So you're pacing these 2 points and the RV, and in this lady, we're also allowing some of her right bundle to contribute. So we move from this ECG to this ECG. Okay? So that's really, I mean, that's like, this lady cannot not respond. Really. I mean, she can not respond, but unlikely to respond to CRT therapy, right? So we've got as good as we could with single point pacing, and then we put in the multi-point pacing, and this is sometimes the sort of changes you might see. Okay. So we've normalised her ECG pretty much. Yeah. She has a normal QRS. She's got a normal QRS of sort of less than 120 milliseconds now. Okay. And this is so we want to use incremental technology to try to make ECGs look like that. Okay. So the lady. We put her in August, we did a live case in October, and she's back dancing, she's gone on holidays, she can walk everywhere she wants, she lives in a hilly part of town, she walks up and down hills, she's no problem, she's a hyper responder to CRT therapy, not just a responder, she's a hyper responder, okay? So really nice, a really nice result there, okay? So sometimes people go, yeah, but this multi-point pacing kills the battery, okay? So the average time, it's variable, but you're looking at around 6 to 9 months longevity hit from this. That means you're taking the device from 7 years to maybe 6.5, 6 1/3 of a year. So what we like to do is ask the patient. We say, okay, we can switch this technology on, and the markers for response are better than if we don't switch it on, but it will make your device last 6 months less or 9 months. And we don't get not one patient says, they all say turn it on, please turn it on. So if we can find a measurable difference between not having it on, I mean this is huge, this difference here is huge, there's no debate here on this one, to that, if you can find a measurable difference, we'd quite like to turn it on and take the longevity hit, it's okay. Okay, because it's not about the battery, right? We shouldn't be putting CRTs in, because I can give you a CRT. Abbott can give you a CRT that lasts 20 years. No problem. 20-year CRT device. Yeah, we can. I can do that. I'll just turn it off. Right? It's just off. Right? So, you know, we should just, we need to get this. Okay, so the next patient was John. He's a bit different. He had his CRT device put in for, he's 56 years old, severe LV dysfunction, smokes too much, probably drinks too much. He's got a long PR interval. So when you have a long PR interval, you should not use Sync AV. The Sync AV is looking at intrinsic, you're looking to use the right bundle. If you've got a long PR interval, we probably shouldn't be doing it. Otherwise you end up with very long AV delays and they're not helpful, okay? So straight away we're not going to use Sync AV in this guy here. So we're going to tune him up. This is his baseline ECG. You can see a slightly prolonged PR interval. Good victim. Good victim for CRT. Very good victim for CRT, right? Strong left bundle, MI, MIHA3. We're going to put a CRT into him and tell him to stop smoking, right? So we told him to stop smoking, he didn't. His QRS is 180. Right? At the start, 180. Implant procedure, pretty straightforward. We put in the traditional one, not the long electrode spacing, because the target vein that we had in him wasn't long enough to take all electrodes. Make sure that this electrode here, this fourth electrode, is in the vein. If it's not in the vein, it will be more likely to pull the lead out. Okay. So we did think about snaring this guy as well, but the doctor who was doing this case was slightly less snary, shall we say. Here's his implant procedure, or his implant X-ray. Happy with that lead position? It's pretty good, isn't it?
Yeah.
There's the LV lead, way out back, RV lead up front, bingo, right? So we've got great leads, we've got great electrical anatomical separation. So we are. So now my job on this thing here is to make it better, right? The doctor's done his job. Now I have to get doing this thing here, reprogramming the electrical activity of the heart. So that's why when people, my friends say, "What does you do for a job?" I reprogram hearts. And I'm like, "Really?" I'm like, "Yeah, reprogram hearts." I'm like, "Wow, that's incredible." Yeah. It's kind of what we do, right? We reprogram hearts, right? We program electrical activity of the heart, right? Underlying rhythms, that we ignore that. Right. So this is out of the box settings. So what do you reckon about out of the box settings? So just as factory send them. Better, right?
Not bad.
It's not bad at all. That's pretty good, that. We'll take that, probably. I'll probably accept that, but we might want to make it better. So let's think about programmer strategy. What should we do? We should find late activated sites, okay? So here we've got a delta of -20. So this means that global QRS is reduced by 20 milliseconds. That's okay. That's pretty good, but we might be able to make it better. So he would probably respond to CRT therapy, probably. If it's decreased by 20, probably respond. So anyway, we're not happy with that. We're not happy with just responding. LV pacing, D1, where's it pacing? Tell me exactly where it's pacing in the left ventricle. Lateral, basal, superior. Moving inferiorly. Yeah? Moving towards his foot, yeah. Okay? And then pacing M2, we can see, so M2 is still basal, right? Still basal. 3, still basal. 4, still basal. So all these leads are in the base. That's why we had to use a short lead, right? Because we couldn't push it very far down. Okay? But anyway, we're pacing the base. It's good. Okay. So then this is using QuickOpt. Like it? VV offset at 55, that's what QuickOpt recommended. It's not bad, is it? That's really, really narrow, right? I mean, wow. So we've got a really, just with QuickOpt, we've improved his delta. By bringing it in 35, we're able to, let's go back to 55. Look at this lead here. You've got to look at all the leads, right? When you just put 2 leads on in a lab, it's not enough, right? You need to see global, because if you don't see V5, you don't see that it's improved. Okay, V5 has probably improved a little bit there, and it's improved even more. Okay, we're doing stepwise VV offsets, and we're going narrower and narrower and narrower, and we're getting close to the point of our narrowest QRS, just pacing 1 point. Okay, so this is down at the base. Okay, so with this ECG, this patient has ECG characteristics of being a good responder, right? We would agree? Because we fixed his left bundle, right? So then the doctor has to do the other stuff, like the drugs, and then the patient has to do his bit by not drinking too much, doing some exercise, yada yada, all this kind of stuff, right? And then, so then latest activation, so this is latest activation, we've now decreased the QRS duration by -30. Okay, so we had a 10 milliseconds increment by doing some VV offsets, but we want to get more, right? We want to see if we can get a little bit more. And now this is pacing using multi-point pacing. Okay, so we get good single point, measure the delta, put on multi-point, measure the delta. So we're pacing 1 and 4, most anatomical separated parts. Not hugely far apart, they're more than 30 millimeters. That's the sort of measurement we want, more than about 30 millimeters of separation between the pacing electrodes and the left ventricular lead. And we're able to bring down his global QRS duration down to 120 from 180, okay? So it's now -60. So we went -20 out of the box, -30 with optimizing single point, -60 now, and this is global ECG with using multi-point pacing. So we decided to go with those settings there, okay? Unfortunately, when he came back, so this was done in, we saw him, put him in August, we saw him at the live, we brought him in for the live case in October. We saw him a week before to make sure everything was okay. He's a non-responder to CRT therapy. Complete non-responder.
Ischemic.
Pardon?
He's ischemic.
He's ischemic, yeah. Yeah, but we've got a lead in a good position, in a non-scarred position, right? How do we know he's in a non-scarred position? We know it's in a non-scarred position because his ECG, his LV ECG is not massively broad. I mean, there's a bit of a delta wave there, but it's not a hugely broad ECG. We weren't in scar. He had an anterior scar.
The more wide the ECG predicts the better response.
Yeah, the more wide the LV pacing ECG, the more likely you are you're in scar, right? And his wasn't hugely wide, and we weren't in scar. We don't MRI everybody. We put CRT. We'd like to, but some places do, but some places have the luxury of MRIing everybody. So, why does he not respond to CRT therapy? Exactly. His PVC activity is mad. He's got like 10-15% PVC activity. So we can tune up his CRT as much as possible, but his PVC activity is too much. So this is probably the reason why he's not responding to CRT therapy. He was also, unfortunately, on a reasonably low dose of beta blocker. So he hadn't up-titrated his beta blocker yet. So he's on 2.5 bisoprolol. So not enough bisoprolol and too many PVCs. So you've got to get it all right. So sometimes people say, well, come on, if you change the ECG, it doesn't make a difference. It does, but everything else has to be good as well, right? So a really good ECG, but with, you know, no drugs, is pointless. You just wasted all your money and your time, right? Pretty much. The good drugs, the up titration is obviously important, which should be done technically before you put it in. Technically. But people don't tend to do that. Okay?
For the multi-site pacing,
Yep.
should we try also the offset? Or
Yeah. This guy had he had an offset, the VV offset. So you have a VV offset between the RV lead and the LV electrodes.
Yeah.
So the LV electrodes are pacing simultaneous. They pace at the same time, and then you have a delay to the RV. Yeah, you usually need an offset.
No, I mean an offset between
Oh,
the 2 points
no.
of the LV.
No, probably not. Mostly not. If you, I'll open up the program. One sec.